So today we will be learning about nephrotic syndrome. It is a very common disorder that we come across in pediatrics, and it is very important from exam point of view, both prof exams and NEET PG. So the nephrotic syndrome is defined by three criteria. We should have heavy proteinuria, that is urine protein more than 1 gram per meter square, or a UP-UC ratio more than 2 mg per mg, and hyperalbuminemia, that is albumin less than 3, and edema. So the edema in nephrotic syndrome usually starts periorbital area, and then it proceeds to pedal edema and ascites. The usual age of onset of nephrotic syndrome is 1 to 12 years, and most of the cases that are seen are usually idiopathic, but in less than 10% cases, they can be secondary causes such as SLE, HSP. So we have to rule out the secondary causes if a patient comes with atypical presentation. Now, the pathophysiology in nephrotic syndrome, it is the glomerular basement membrane of the nephron has three layers. There is an endothelium, the Bowman's capsule, and then there is an epithelial layer. So there are slit diaphragms in these three layers that allow the passage of some micromolecules in a normal condition, like alpha 2 microglobulin, but they do not allow the passage of large molecules. So molecules less than 20,000 Daltons can pass through the basement membrane, but they are usually reabsorbed. And also there is a negative charge on the endothelium, so the negative particles are usually not allowed to pass through the basement membrane. Only free positively charged and neutral molecules of smaller than 20,000 Daltons usually pass through the glomerular basement membrane. Now, nephrotic syndrome is typically a podocytopathy. There are podocytes on the endothelial layer, which are foot processes interdigitating with each other, which make the slit diaphragms. So when the foot processes are effaced, the slits become larger, and they lose their property of selective filtration, and hence albumin and globulin also seep through the basement membrane. Now, why the edema develops? So we should know that because the albumin, which is going through the glomerular basement membrane, the patient is losing albumin in the urine. So there is hyperalbuminemia in the body, which will cause a decreased oncotic pressure, and it will cause third spacing of the fluid. That is why the patient will have edema. And that edema is further exacerbated because there is third spacing of the fluid. The RAS system of the body, it perceives it as hypovolemia. So the RAS is activated, and there is further sodium and water retention in the body, causing more edema. Now, there are a few definitions that are important for nephrotic syndrome. So there is one that is initial episode of nephrotic syndrome. It is when the patient first presents to you before having any other episode of nephrotic syndrome. That is the first episode of nephrotic syndrome. So what do we the other definitions? Yes, of course, it is a chronic disease. It can have relapses, it can have remissions. Remission, what do we say what a remission is? So what we usually do, every nephrotic patient, they usually are asked to check their urine protein daily by a dipstick, or a UP-UC ratio can be done. So at home, we usually advise them to do it by a dipstick. So a urine protein, which is nil or trace. So a dipstick has nil, trace, +1, +2, +3, and +4. So we can check it with the bottle. It has grading in that. So urine protein nil or trace, or UP-UC ratio less than 0.2 mg per mg for 3 consecutive early morning samples, we consider this as a remission. And a relapse is a urine protein more than equal to 3 plus, or a UP-UC ratio more than 2 mg per mg for 3 consecutive early morning samples. That is known as relapse, given the patient has been in remission previously. Now, what is a partial remission? A partial remission is a urine protein +1 to +2, or a UP-UC ratio 0.2 to 2 for 24 or 24-hour urine, that is 4 to 40 mg per meter square, and serum albumin is more than equal to 3, and there is no edema. So basically, there is no the criteria is not sufficing for remission as well as relapse. That is what we consider as a partial remission. Now, relapses in nephrotic syndrome are quite common. Usually, what we see is even with a upper respiratory tract infection, which are very common in children, in school-going children, can cause a relapse. Any infection in the body can cause a relapse. So, what is a frequent relapse? A frequent relapse is 2 or more relapses in 6 months following therapy of the initial episode, or or it can be more than equal to 3 relapses in any 12 months period. So it is 2 or more in 6 months following the initial episode. Like if the initial episode was in January, so till June, if there are 2 or more relapses, or in any 12-month period, they are more than or equal to 3 relapses, that is a frequent relapser. So what is the importance of this, the frequent relapses? So what happens is when we give treatment for nephrotic, the typically what we do is we give steroids to the patient. So now if a patient has frequent relapses and we give long-term steroids, it can cause a lot of side effects. As you all must know that steroids cause a lot of side effects. So to prevent that in frequent relapses, we can change the therapy, which we will discuss later. So it is important to classify the patient, if the patient is a frequent relapser, or is the patient steroid dependent or steroid resistant. That is why we need to know all these definitions. Now, steroid dependence. So steroid dependence is 2 consecutive relapses when on alternate day steroids or within 14 days of its continuation. So okay, so we will cover the treatment later. This is the definition of a steroid dependent, that is 2 consecutive relapses when on alternate day steroids or within 14 days of its continuation. And what is steroid resistant? Steroid resistance is lack of complete remission despite therapy with daily prednisolone at 2 mg per kg, that is 60 mg per meter square daily for 6 weeks. So even if the patient is taking therapy for initial 6 weeks with daily steroid at 2 mg per kg, even then the patient has not achieved complete remission, we would call them steroid resistant, and they usually have a different treatment protocol altogether, and even they might have different causes. It might not be a minimal change disease. Now, complicated relapse is a relapse which is associated with life-threatening complications like hypovolemia or severe infection, that is peritonitis, cellulitis, meningitis. Cellulitis is quite common in nephrotic patients because they, what happens is that they develop edema to such level that the skin barrier breaks very easily and might cause cellulitis. And the third is thrombosis. It is a prothrombotic state. Nephrotic syndrome is a prothrombotic state. So, and then there is congenital nephrotic syndrome. So, congenital nephrotic syndrome is a nephrotic syndrome which occurs within the first 3 months of life, and you do not need to know much about congenital nephrotic syndrome except that it is mostly genetic in nature. One of the organisms that can cause congenital nephrotic syndrome is syphilis. Syphilis can cause a congenital nephrotic syndrome in a baby. Other than that, it is mostly genetic, and it is not treated by steroids, is usually treated with ACE inhibitors. Now, what are the investigations you need to get done for nephrotic syndrome? So now initially we have to confirm the diagnosis, and if there is an atypical presentation, we will rule out the secondary causes. So firstly, of course, you have to get a urine analysis done. Urine analysis will tell you about the presence of protein in the urine. So what we do is in our hospital, sometimes we get a urine protein by dipstick done and a urine analysis done. But the best approach for to quantify urine protein would be a UP-UC ratio that we have discussed, has to be more than 2 mg per mg for defining a relapse. And we have to get a CBC done, of course. We have to get a blood urea creatinine done. We have to get electrolytes done, serum total protein, albumin, and cholesterol. So earlier, a few years back, what we used to study is hypercholesterolemia was also in the definition of nephrotic syndrome, but not anymore. It is there. Hypercholesterolemia is seen in nephrotic syndrome, but it is not in the definition of nephrotic syndrome. We get a tuberculin test done. So what is the definition? What is the requirement to get a tuberculin test done? So what happens is when we give long-term steroids to any patient, we make them immunodeficient. So if a patient is immunodeficient, as you know, in India, TB is so rampant. Almost every one of us might have had a primary infection which got latent because of our immunity. But if that patient is made immunosuppressed, so what happens is that patient might have a flare-up of tuberculosis. So we have to get a tuberculin test done to look for latent TB infection. Now, what are the additional investigations? So the additional investigations are usually the ones to rule out a secondary cause of nephrotic syndrome. So now, see, firstly, nephrotic syndrome is idiopathic in maximum cases in 90 to 95% of cases. Now, in that, the most common thing, okay, so this is important for your exam point of view. Most common pathology that we see in the kidney is a minimal change disease. What is a minimal change disease? There is only effacement of the food processes of the podocytes. So when you get a kidney biopsy done, so ideally we do not get a kidney biopsy done in nephrotic syndrome, which are quite vanilla a type of nephrotic syndrome. We do not get a kidney biopsy done. So if there are any complications or any indications, we will discuss the indications of renal biopsy later on in this segment. So at that time, we get a renal biopsy done. So if for academic point of view, we get a renal biopsy done. In a minimal change disease, you will not find any finding in the light microscopy. We will not find anything in immunofluorescence. There are no, like, in other diseases, in HSP, in IgA nephropathy, in other diseases, you get deposits in the kidney. There will be no deposits in the kidney in minimal change disease. There will be no finding in the light microscopy. Only in electron microscopy, you will find the effacement of the food processes. That is the only finding you will get in minimal change disease. Now, some patient can also have focal glomerular sclerosis, focal segmental glomerular sclerosis, FSGS type. So they are usually more severe type. They will have mostly they will present as steroid-resistant nephrotic syndrome, but they're quite less in number. Maximum 80% of the patients would be minimal change disease. Other than that, even so, these are both idiopathic type. But if a patient comes with you, like usually what we see is nephrotic syndrome very seldom, बहुत rarely होता है कि it will come with hematuria as well. So if the patient is coming with hematuria, so we call it as a nephrotic nephritic picture. We can also get what we serum complement C3, C4 level done in an elder patient. If a patient is 11, 12 years old, especially if it's a female, we can also get ANA done because SLE also presents as nephrotic syndrome. We get an ASLO done for post-streptococcal glomerulonephritis. So the indication for all of them is if there is sustained hypertension, if there is gross or persistent microscopic hematuria, or there is AKI without any hypovolemia. So prerenal AKI can occur in nephrotic syndrome when there is hypovolemia due to low albumin and third spacing of the fluid. So prerenal AKI can be present, but it is usually resolved by giving fluid to the patient. But if there is AKI without any hypovolemia, then we have to suspect some secondary causes which are causing damage to the kidney. If there has been any history of jaundice or liver disease, we also get Hep B, Hep C done. They also cause, they can also cause secondary nephrotic syndrome. And if there has been positive tuberculin test, or there's a history of contact, and there's a suspected lower respiratory tract infection, then we get also a chest X-ray done to see if there is any latent TB infection line. If there is a latent TB infection confirmed, then when we start steroid, we also give prophylactic isoniazid therapy to the patient so that they do not land up in tuberculosis. Now, what is the approach to the first episode of nephrotic syndrome? So this is where you can revise your definition for steroid dependence and steroid resistance. So if there is an initial nephrotic syndrome, we will get all the investigations done that we had already discussed. Now, if there is no other investigation of secondary causes is positive, and it is just plain simple initial episode of nephrotic syndrome without complications, we start steroids. So steroids are given, so we give a 6+6 regimen. 6+6 is initial 6 weeks, the patient gets steroid for 2 mg per kg, that is 60 mg per meter square daily. And then if after 6 weeks, when the patient is in remission, so usually they achieve remission before 6 weeks only, if it is just a non-complicated initial episode. After 6 weeks, we give steroid for another 6 weeks, which is an alternate day therapy, 1.5 mg per kg or 40 mg per meter square, and then we stop. We do not taper any further. We stop. We give for 6 weeks daily, that is 2 mg per kg or 60 mg per meter square. Then we give 6 weeks alternate day at 1.5 mg per kg or 40 mg per meter square. Now, this is the treatment for initial episode of nephrotic syndrome. After this, we stop the steroids, and whenever there are relapses, they are treated as per the protocol of a relapse, which we'll discuss later. Now, what happens is if there is only a partial remission, or so now the definition for steroid resistance comes in. So if in the initial 6 week, when we are giving 2 mg per kg daily steroid and the patient is still not in remission after 6 weeks, we consider this steroid resistant, and in that case you should refer the patient to the pediatric nephrologist. They will plan a biopsy for the patient, and we do not further give steroids. We start the patient with calcineurin inhibitors. So they are tacrolimus and yes. So we start with calcineurin inhibitors, that is tacrolimus and cyclosporin. Now, moving on to the treatment of relapse. So if the patient comes in relapse, so as we have already discussed, that initially, it is a disease of childhood. Patient can be a 4-year-old child, a 5 or 6-year-old child. They go to school, they are very prone to having some URIs also. So even a URI can trigger and relapse and cause a relapse in nephrotic patients. So whenever there is a relapse, what we do is we do not give a 6+6 therapy all over again. We give prednisolone at 2 mg per kg daily until remission. Remission is what? Your urine protein has to be nil or trace for at least 3 consecutive days in an early morning urine sample, or UPUC ratio less than 0.2 mg per mg. So we give that till remission, and then we give an alternate 1.5 mg per kg therapy only for 4 weeks, and then we stop. So now, infrequent relapses. So we had discussed the definition of frequent relapses. Now, infrequent relapses is less than equal to less than 2 relapses in the first 6 months is an infrequent relapse. So now if the patient is just an infrequent relapser, so what we do is we just treat each relapse just as we have discussed, that is 2 mg per kg till remission, and then 1.5 mg per kg on alternate day for 4 weeks. That is how we treat an infrequent relapses. Now, when we're discussing the definitions, I had told you if a patient is a frequent relapser requiring steroid again and again, we cannot just keep on giving steroids, right? And even in a steroid dependent, what is a steroid dependent? That after discontinuation of the therapy, there are 2 consecutive relapses, or if on alternate day regimen, if there are 2 consecutive relapses, or within 14 days of stopping the therapy. So that patient has a high requirement for steroids, and a frequent relapser will also have a high requirement for steroids. We cannot keep on giving steroids to the patient daily for such a long term. It is because they are growing children. They will affect everything. They will affect their weight, their height. It causes a lot of problems. It can cause diabetes in the patient, hypertension, obesity. So what we do is there is a regimen. We give the patient long-term therapy with prednisolone on alternate day. We call it LTAD, long-term alternate day therapy. So a long-term alternate day therapy is we give steroid at a very low dose on alternate day for long term. We can give it for even a year. So it will not cause as many side effects as a full blown steroid therapy would. So now what happens is, if there is a frequent relapse that is controlled with LTAD, well and good. But when there is steroid dependence or frequent relapse is not controlled on LTAD, so along with, in the cover of LTAD, we can give levamisole to the patient. We start levamisole, we give levamisole to 1 to 2 years to the patient. It is also given on alternate day. I don't think you might need to learn the doses of all the other drugs. So this is how we go on with this. These are the and some there are some other drugs that we can definitely use for steroid dependence. Other than levamisole, we can give the patient cyclophosphamide, we can give mycophenolate mofetil, we can give tacrolimus and cyclosporin, which are also very, very, very important for steroid resistant nephrotic syndrome. And we can give rituximab to the patient. Usually a pediatric nephrologist should handle such cases, but for exam point of view, you have to know the drugs that are important. Now moving on, late steroid resistance also, what we do is we usually plan a kidney biopsy for the patient. Yes, and also if there is a steroid resistant case, or a nephrotic syndrome that has hypertension, we start ACE inhibitors or ARBs, because they prevent renal remodeling, and they're renoprotective, and they also decrease albuminuria. Now, what is LTAD? So LTAD is therapies initiated at a dose of 0.5. So see how much of a difference there is in the doses. LTAD is a very low dose steroid, 0.5 to 0.7 mg per kg on alternate day. We can give it for a year. During episodes of fever and respiratory tract infection, we can prednisolone can be given every day, because this is a stress condition, so we have to prevent relapse. So instead of alternate day, we can change it for everyday regimen for 5 to 7 days. We have to monitor the patient continuously for steroid toxicities, including obesity, their short stature. You have to get a glucose tolerance test done. Cataract, we have to look for posterior subcapsular cataracts, are very common with steroids. We have to look for osteoporosis. There are n number of complications that can occur with the long-term steroid use. Then if, as I've told you, if the patient keeps on relapsing even on a long-term alternate day therapy, we add steroid sparing agents. So steroid sparing agents are usually levamisole is the first one that we try. If not levamisole, we can go for MMF, we can go for cyclophosphamide. In cases who are like not controlled by these, we can go for tacrolimus, cyclosporin, or even rituximab. Now, steroid resistant nephrotic syndrome. So steroid resistant nephrotic syndrome is very challenging, because they have a variable response to steroids and even immunosuppression, and they have a very high risk to progression to kidney failure. In these cases, we usually also get a renal biopsy done to look at the status of the kidney. Might be FSGS instead of minimal change disease, so they might land up in end-stage renal disease with you. Now, the first line for treatment for steroid resistant is, if you have diagnosed a steroid resistant case, you have to give calcineurin inhibitors, that is cyclosporin and tacrolimus. Now, what are the complications of nephrotic that we have to tackle? First one is definitely edema. So if there is only a mild edema, mild periorbital edema, you do not need to give any diuretics. But if there is moderate edema, or even severe edema, or albumin is if there is moderate to severe edema, we have to give furosemide. We can give furosemide. We can even give metallazone to the patient. We usually prefer furosemide. Now, what happens is furosemide will decrease your edema, and it will. Why do we need to decrease edema? We need to decrease edema because very high chance to get cellulitis. If you have very severe edema, the skin barrier will break down very easily. Even with a scratch of a nail, it can break down. It can cause cellulitis. Now, in patients that have hypovolemia and there is albumin is less than 2, we also give IV albumin to the patient along with furosemide. Infections, peritonitis is common, pneumonia is common, cellulitis is common, and most common organism that causes these in patients with nephrotic is streptococcus. Now, about immunizations. So you have to know about immunizations. So any child, not I'm not talking just about nephrotic, any child who has taken prednisolone, a steroid at a full dose, prednisolone 2 mg per kg for more than equal to 14 days, we consider the child immunosuppressed. That is, their immunity is effectively suppressed right now. They are immunosuppressed patients. Now, so we cannot give live vaccines to these patients because if you give live vaccines to immunosuppressed patients, they can get the disease, right? We have studied it in vaccination that you do not give live vaccines to immunosuppressed patients. So we can give killed, inactivated toxoids, we can give all of these vaccines, but live vaccines we do not give till we have weaned off the immunosuppressive therapy. That is, steroids have been stopped for at least more than a month. That is when we consider that the patient has become immunocompetent again. And if the patient was on cyclophosphamide, you have to wait at least 3 months, and at least 6 months if the patient was on rituximab. And now OPV. So OPV, we have heard it gives a herd immunity. It gives a herd immunity and passive immunity also. So because it is shed by the fecal-oral route, so it provides immunity to others also. But what happens is, in this case, it might cause disease in the immunosuppressed patient. So OPV is usually avoided even in the siblings of nephrotic patients and their household contacts, because we do not want the OPV to reach the nephrotic patient in any way. Now, diet. So we usually ask the patient to have some salt restriction because it will cause more edema. Otherwise, when the patient doesn't have edema or there is no AKI, when the patient is in remission, we do not need to restrict the salt and fluid. Now, hypertension can be managed by, we can make the patient be more active, lifestyle modification, and we can restrict the salt intake of the patient, and avoiding long-term prednisolone dosing, as we have already discussed, it causes hypertension. We can give ACE inhibitors or ARBs. They are the first choice of medication for hypertension, nephrotic syndrome, as they're renoprotective. Now, coming quickly to the indication of renal biopsy. When do you have to get a renal biopsy done in nephrotic syndrome? So if there is persistent microscopic or gross hematuria, you get a renal biopsy done. If there is AKI despite of correction of hypovolemia, you have to get a biopsy done, because it could be a secondary cause. That is because, SLE will do both. It will present as nephrotic syndrome, and it also eats away at your kidney. It causes renal failure. It causes end-stage renal disease. So if there is AKI without hypovolemia, you get a renal biopsy done. If there's systemic features like there's fever, rash, arthralgia, and these are all common in rheumatic causes like HSP. It is common in SLE. So if there are any systemic features that are consistent with the secondary cause, you get a renal biopsy done. If you get a C3 level and it is low, you have to get a renal biopsy done. If there is steroid resistance, as I told you, steroid resistant patients have to get a renal biopsy done to look at the status of the pathology in the kidney, even if it is an initial resistance or a late resistance. Prior to therapy with calcineurin inhibitors. So what happens is calcineurin inhibitors can themselves cause damage to the kidney. So you have to, before starting the therapy, you have to get a baseline done, baseline status of the kidney. You have to check. So that is why we have to get in steroid resistant patient, you anyways get a renal biopsy done because of steroid resistance, and also because we have to start calcineurin inhibitors. But in steroid dependent, in whom you are starting calcineurin inhibitors, you have to get a renal biopsy done. So this is grossly what we need to know about nephrotic syndrome. Now, again with the MCQs, so these are just three MCQs that I think would be important. So, which is the first line treatment for steroid-resistant nephrotic syndrome? A is levamisole, B calcineurin inhibitors, C cyclophosphamide, D MMF. So now all of these are steroid sparing agents, but calcineurin inhibitors are the first line of choice, first line of treatment for steroid resistant nephrotic syndrome. So the answer would be B. UC ratio diagnostic for nephrotic syndrome is it is just a factual question, nothing very conceptual about it. It's more than 2 mg per mg, which is the diagnostic ratio. So the answer would be B again. And most common pathogen implicated in infections in patients with nephrotic syndrome is A, Streptococcus pneumoniae. Thank you.
Yes, doctor, it was good. I've recorded the session, so I'll forward it to the team. I'll get back to
Okay.
you in 3-4 days. Huh?
Okay, sir. Okay, thank you, sir.
Thank you so much.
Okay.